Respected teachers, seniors, colleagues, and my dear students. Today we will present our clinical combined rounds on behalf of Department of Medical Gastroenterology. Ascites is a common problem that is seen by all physicians, surgeons, gynecologists. We are dealing with a case which presented to us and has refractory ascites, and with multidisciplinary treatment and approach it was evaluated. So we'll just start with the case of our 27-year-old male who presented to us with refractory ascites. So I'll invite Dr. Dhiraj from our department to start with the case history.
Good morning, respected teachers, my seniors, and my colleague. I am Dr. Dhiraj. Today's clinical combined round is about a 27-year-old male with a refractory ascites, which I prepared under guidance of my HOD sir, Dr. Subham Dadheech sir, and Dr. Rajkumar sir, and Dr. Apurv Mathur sir. Presenting complaints: the young male had presenting complaint of low-grade fever and anorexia for 1.5 months, abdominal distension and weight loss for 1 month. The fever was low-grade. It was with evening rise and night sweat. He could eat 5 chapatis before the disease, but that came down to 1 when he presented. He noticed a weight loss of about 6 kgs with loosening of clothes. Abdominal distension was progressive and non-responding to diuretics, and he needed repeated ascitic tapping twice a week. Negative history: there was no history of jaundice, GI bleed, altered behavior, pain abdomen, diarrhea, decreased urine output, swelling of feet, facial puffiness, cough with expectoration, shortness of breath, chest pain, and recent surgery or trauma. Personal history: he does not consume any alcohol or tobacco. His father had pulmonary tuberculosis 2 years back, for which he completed ATP. In treatment history, he presented outside tertiary care hospital, where he was evaluated with routine blood investigation, radiology, FNA, and was started on ATP. On ATP for a month, he needed repeated ascitic tapping, which was twice per week, about 4 to 5 liters. Now, summarizing the initial history, we have a 27-year-old young male with low-grade fever and night sweat, anorexia into 1.5 months, weight loss and abdominal distension into one month, on ATT for 1 month. Ascites was non-responding to diuretic and needed repeated ascitic tapping without any jaundice, GI bleed, altered behavior, pain abdomen, shortness of breath, decreased urine output. At this point, we like to keep the differential diagnosis of infective peritoneal TB, because India is endemic country for tuberculosis, and the patient is having constitutional symptom of TB like anorexia, weight loss, and out of proportion decreased appetite, and ascites. We like to keep second DD as neoplastic or peritoneal metastasis. Third will be chronic liver disease, as it is the most common cause of ascites. And the last is mixed ascites, because patient can have 2 diseases simultaneously, like infective and neoplastic. Less likely causes are pancreatitis, because patient did not have any pain, constructive pericarditis, as there was no shortness of breath, orthopnea, and very less likely collagen vascular disease due to decreased low incidence. In general physical examination, patient vital were mostly normal. At the time of examination, he was having low-grade fever. His temperature actually was 99.6 degrees Fahrenheit. He was moderately built. He was cathexis. His height was 180 centimeter. Weight was 54. His BMI was 16.7. His pallor icterus clubbing, cyanosis, edema were absent. He had palpable bilateral cervical and inguinal lymph node, which were discrete, firm. Largest size was 1 centimeter in left cervical region. He had palpable bilateral cervical and inguinal lymph node, which were discrete, firm. Largest size was 1 centimeter in left cervical region and 2 centimeter in left inguinal region. His JVP was not raised. His axillary pubic hair gonad was normal. There was no gynecomastia. There was no palmar edema, spider nevi, or depressive contracture. On systemic examination, per abdomen inspection revealed abdomen was distended in all quadrants and umbilicus was everted. There were no scar, no sinuses, no spider nevi, no visible veins, no visible peristalsis. Palpation, liver, spleen, gallbladder were not palpable. There was no cardiac rigidity, tenderness, and local rise of temperature. On percussion, shifting dullness was present. Liver spine was normal. On auscultation, there was no venous hum, dewy, bowel sound, were present at 9 per minute. Other systems were unremarkable. So that at the end of history and examination, the summary is a young 27-year-old male with low-grade fever, weight loss, abdominal distension, on ATT for 1 month, needed repeated ascitic tapping, having palpable cervical and inguinal lymph node with ascites without hepatosplenomegaly and icterus. So the diagnosis narrows down to, still I would like to keep the first diagnosis as infective, as India is having most prevalent endemic zone for TB, then neoplastic. Chronic liver disease is less likely because the patient do not have a history of consumption of alcohol and other mixed ascites. Then we investigate the patient with routine blood counts, routine blood investigation like CBC, LFT, RFT, in which the significant finding was his ESR was raised, which is 68, and CRP was 45. His LFT, liver function test, and renal function test were normal. Other than amylase, lipase, and tumor marker like CEA, CA99, alpha fetoprotein were normal. Outside cervical lymph node FNAC was suggestive of epithelioid cell and Langerhans giant cells. His Montius test was negative. His HIV marker were negative. On other investigation like chest X-ray, upper GI endoscopy, 2D, they are all normal. USG abdomen revealed multiple pre-aortic, periaortic, pre-caval iliac lymph nodes with moderate ascites, with normal liver, GB, pancreas, spleen, and kidney. Coming to the ascitic fluid analysis, it was milky white. SAG was low, it was 0.9. Triglyceride was high, 448. That reference range for which is to less than 200. So it was suggestive of a chylous ascites. Protein was again high. ADA was high. The reference range is 36 and it was 46. Fluid amylase level to rule out any pancreatitis, it was normal. Lymphocyte count, leukocyte count was raised, 6,200. 98% out of it was lymphocyte. In microbiology, AFB staining, gram staining, culture sensitivity, all were negative, and CBNR did not detect any microbacterium. For further planning, in view of low SAG, chylous ascites, and abdominal lymphadenopathy, we evaluated the patient with CCT, whole abdomen and thorax, and cervical lymph node excision biopsy. In CCT chest and abdomen, CCT chest revealed mediastinal lymph node and mesenteric lymph node, pelvic lymph node, bilateral inguinal lymph node with moderate ascites. There was omental nodularity and caking, and also miliary modeling in lung field. So at that point, most likely diagnosis was tubercular etiology, and differential diagnosis was lymphoma. So then we did a cervical lymph node excision biopsy for left cervical lymph node. It came out to be lymphoproliferative disorder. Then Department of Oncopathology helped us taken, immunohistochemistry was applied, and it turned out to be a classical Hodgkin lymphoma. Simultaneously, for the staging, we also did bone marrow aspiration and bone marrow biopsy. That did not show any lymphomatous involvement. So now to further discuss the details of the biopsy, I would like to invite Dr. Aditya Mundra from Department of Oncopathology.
Thank you, Dr. Dhiraj. A very good morning to all the respected professors, seniors, and fellow residents. I'm Dr. Aditya Mundra from the Department of Oncopathology, and I'll be discussing the histopathological aspects of this particular case. Gross examination, received excision biopsy of the left cervical lymph node. The diameter of the largest lymph node was 1 centimeter, and cut surface examination revealed homogeneous gray white appearance. Microscopic examination revealed diffuse distortion of normal lymph node architecture, and high power examination revealed presence of large atypical cells which were 6 to 7 times the size of a normal lymphocyte. These atypical cells had a bilobed nucleus, prominent nuclear membranes, and a vesicular chromatin with prominent nucleoli. The size of the nucleoli was comparable to the size of a small lymphocyte. So I would like to ask the audience, what are these cells and what is this characteristic appearance called as? These are diagnostic Reed-Sternberg cells, and they have a characteristic owl-eye appearance. The picture on the right hand side shows a mononuclear variant of a Reed-Sternberg cell. Immunohistochemistry was performed and CD3 and CD20. CD3 and CD20 were negative in the Reed-Sternberg cells, although the surrounding lymphocytes picked up CD3 much more than CD20. CD15 and CD30 showed characteristic membranous and a Golgi pattern positivity, and PAX5 showed dim positivity within the Reed-Sternberg cells. So summarizing all our findings, there was total effacement of normal lymph node architecture. There were presence of Reed-Sternberg cells. These Reed-Sternberg cells were surrounded by mixed population of inflammatory cells, and the Reed-Sternberg cells were positive for CD15, CD30 and PAX5 and negative for CD3 and CD20. So the final diagnosis of classical Hodgkin's lymphoma was given. For further staging of the disease, I would like to call upon Dr. Subham from the Department of Nuclear Medicine. Thank you.
Thank you, sir. Good morning to all the respected faculty members, seniors and colleagues. Patient was sent to the Department of Nuclear Medicine for baseline PET-CT. Baseline evaluation was done. These are maximum intensity projection images of baseline PET-CT for disease staging. Physiological uptake is noted in brain and myocardial. Multiple FDG-avid lesions are noted on both sides of diaphragm, and diffuse increased bone marrow activity is also noted. Region involved above diaphragm are cervical region, in which we can see bilateral submental, submandibular, bilateral level 2 to 5 cervical, bilateral supraclavicular lymph nodes, and this is an axial section showing FDG-avid supraclavicular lymph nodes. FDG-avid bilateral internal memory, mediastinal, paraesophageal, anterior diaphragmatic and bilateral retrocranial lymph nodes were also noted. Below diaphragm, FDG-avid multiple lymph nodes in abdominal, retroperitoneal, bilateral pelvic and inguinal regions are noted, along with low-grade FDG-avid gross ascites. We can see that there is involvement of mesenteric lymph nodes with gross abdominal ascites. Along with this, low-grade FDG-avid diffuse ground glass nodule haziness with multiple miliary nodules were noted in bilateral lungs, which were more prominent on upper lobes. These findings are more in favor of infective etiology, tuberculosis. So according to Lugano classification for Hodgkin's and non-Hodgkin's lymphoma, if the single site or lymph node is involved, this is stage 1. More than one lymphatic site or regions involved is stage 2 on same side of diaphragm. If more than one lymphatic site or on both the sides of diaphragms is involved, it is stage 3. And one or more extra lymphatic organs is involved, it is stage 4. And according to clinically, according to symptoms, it is presence of A or B symptoms, which is group B symptoms are fever and night sweats. So in our patients, we had presence of group B symptoms, so the stage was stage 3B. So to conclude, FDG-avid multiple lymph nodes on both sides of diaphragm, Lugano stage 3B, and diffuse increased FDG-avid uptake in entire visualized marrow with no morphological lesion, likely reactive bone marrow uptake, and possibility of infective etiology tuberculosis coexisting with lymphoma can also be considered. So the patient was referred back to the Department of Gastroenterology.
Thank you, Dr. Subham. So now we stand at two diseases, one with confirmed diagnosis and one with strong evidence of having the disease. So for the Hodgkin lymphoma, we consulted clinical hematology department, and they took up the further management. And in view of raised ADA level, miliary mottling in chest or mental caking, father having history of pulmonary tuberculosis 2 years back, outside FNS history of epithelioid cell that was before almost 2 months of ATT, and patient was to be about to started on immunosuppressive drug, that is chemotherapy. So after consultation with the respiratory medicine department, we made a decision to continue with the ATT. So now to talk about pulmonary tuberculosis and whether to continue or not, I would like to call Dr. Apurv Mathur from pulmonary medicine department.
Thank you, sir. Good morning, respected teachers, seniors, and my fellow colleagues. So the case till now is we have a 27 years old male who presented with complaints of low grade fever, anorexia, abdominal distension and weight loss since 4 weeks. The patient had a positive family history. His father had pulmonary tuberculosis depending on the further investigations like the ascitic fluid analysis which showed high protein, high ADA with lymphocytic predominance, the diagnosis of the differential of tuberculosis was considered. The patient was already on 4 weeks of anti-tubercular therapy. His CCT examination showed miliary-mottling and involved various lymph nodes, but his excisional lymph node biopsy of the cervical region showed classical Hodgkin's lymphoma. So now the question was, since the patient has been already on 4 weeks of anti-tubercular therapy and we have another diagnosis of lymphoma, should we continue with the anti-tubercular therapy? So the points in favor of continuing the treatment is that India is endemic for tuberculosis. In the global tuberculosis report of 2021, there were 10.6 million people affected worldwide and India contributed around 30% of the total cases. Also, the duration of the symptoms of the patient and the positive family history pointed in the direction of tuberculosis. Along with this, ascitic fluid reports, the fine needle aspiration cytology suggesting epithelioid and giant cells, the CCT reports, etc. were pointing towards tuberculosis. However, there was no microbiological confirmation. And we can also see that the sensitivity of these microbiological tests is very low, like that of acid-fast bacilli smear is less than 2%, that of TB-PCR is 20%, that of cartridge-based nucleic acid amplification test is around 29%. So the chances of getting a positive culture is very low. Also, the biopsy report was suggestive of Hodgkin's lymphoma, and there can be cases of false positive high ADA, as ADA can be raised in other bacterial infections, it can be raised in lymphomas or other collagen vascular diseases. So then we reviewed some literature and we found a case report which was published in Lung India edition of 2014. In this there was a 28 years old female who had complaints of fever and cough with expectoration and had cervical lymphadenopathy. On histopathological examination, the diagnosis of tuberculosis was confirmed and she was started on anti-tubercular treatment. However, she did not feel any improvement in clinical picture, so she again consulted in the hospital and again her investigations were repeated. There was increase in the size of the lymph nodes on radiological examination. So again a histopathological examination was done of the cervical lymph node, and this time the diagnosis of Hodgkin's lymphoma was found. So along with anti-tubercular therapy, she was started on immunosuppressive drugs, and after that she showed improvement. There are some other case reports by various authors, as we can see here. So these have shown that tuberculosis and lymphoma can exist together. So we have to continue with the anti-tubercular therapy. As India is endemic, there is high chances of the patient getting tuberculosis, and if we plan to start the patient on any immunosuppressive drugs, the existing infection can flare up. So we recommended with the continuation of anti-tubercular therapy. Now I invite Dr. Disha Satya ma'am from Department of Clinical Hematology to talk about further management. Thank you.
Now I'll be discussing about the management of Hodgkin's lymphoma in this patient. So before initiating chemotherapy, it is staging and prognostic factors help predict the likely outcome of the patient and decide the line of management for the patient at diagnosis. So as discussed earlier on staging PET, patient had lymph node above and below the diaphragm involvement, that is stage 3, and patient also has had presence of B symptoms, fever, night sweats and significant weight loss, that makes it stage 3B. And so as per the international prognostic score, it constitutes 7 major adverse prognostic factors that include albumin, hemoglobin, albumin less than 4, hemoglobin of less than 10.5, male gender, stage 4 disease, and age more than 45 years, leukocytosis and lymphocytopenia, and 4 of these were present in our patient. So he comes into the high risk category. So treatment, initiating chemotherapy was not simple in this patient. Patient was not a stable patient. He had poor nutrition and general condition, had concomitant tuberculosis, recurrent chylous. So the overview of chemotherapy.
Doctor, what do you mean by chylous ascites?
So chylous, patient had some milky white ascites on tapping.
कितनी तरह के ascites हो सकती
Sir, it's a
Suppose you are
right, sir.
classifying on the basis of color.
Right.
How many types of ascites you can anticipate?
Sir,
There
so
is-
depending
there is
upon the
clinical
SAG,
significance of each and every.
right. Sir, there can be high SAG or low SAG ascites. That would be
That is
exhibitive and
that is based on the serum ascites albumin gradient.
right.
That is different. You
Okay,
can
sir.
differentiate whether it is a numerical factor or whether it is the malignancy or something else. Tuberculosis is the factor. So I am talking just of the color.
On the color.
What do you mean by ascites? What caries?
Yes, sir.
What do you mean by ascites?
So accumulation of fluid in the peritoneal
Kitna
cavity.
fluid?
Sir, physiological is around 50 ml. More than that would be.
Are you sure? Shifting dullness का बात है।
Sir,
कितना fluid होना चाहिए?
Sir, for shifting dullness to be present, there should be more than 500 ml of fluid.
At least 1.5 liter has to be there for the shifting dullness. Ascites word कहाँ से आया? What is the origin of this word? Ascites. Anybody from the audience? Ascites is the word which I was just reading on coming to the hospital. It is the word, Greek word askos, A-S-K-O-S, which means bag or pot. From there it has been generated as ascites. It is a Greek word, ascites. There might be like black colored ascites or
Sir, in
Plain
hematology,
ascites
in
or
hemoperitoneum.
beer type of ascites. So many ascites
Right, sir.
which are important to differentiate. Ascites word समझ गए ना ये कहाँ से आया? Ascos,
Yes.
Greek word. आप लोगों को यार पैथोलॉजी और ये क्लिनिकल मेडिसिन वाले ज़्यादा आना चाहिए.
So now overview of the management. Patient had advanced Hodgkin lymphoma. So the plan is to start chemotherapy, ABVD, which I'll be discussing in the next slide. And then a response assessment is done with an interim PET analysis. If the response is good, that is a dual score of 1 to 3, which will be discussed ahead, and or a poor response, based upon that, we either continue the ABVD regimen or we escalate the chemotherapy. So ABVD protocol. So this is the most popular and the least toxic protocol for Hodgkin's lymphoma, and so it constitutes doxorubicin, bleomycin, vinblastine, and dacarbazine. And it is a 28-day cycle. Chemotherapy is administered on day 1 and day 15. Further management, so first we had given 50% of the dose for cycle 1, day 1 chemotherapy due to poor general condition of the patient. And so subsequently complete dose was administered as the general condition of the patient improved. After 2 cycles of chemotherapy, patient had become afebrile, the appetite had improved, cervical lymphadenopathy had resolved, and the chylous ascites had not improved and was requiring repeated paracentesis. For which we decided to go ahead with lymphoscintigraphy and to identify the site of leak, and an interim PET CT for the response evaluation was done. Now I would like to call Dr. Subham for further discussion.
The patient was sent back to the Department of Nuclear Medicine for interim PET CT as well as lymphoscintigraphy. So interim PET CT is...
Lymphoscintigraphy क्या होती है?
Sir, since the ascites was chylous, so we were suspecting leak of lymph. So lymphoscintigraphy study of lymphatic channels on gamma camera we have. Sir, in interim PET-CT, which is done for response evaluation, and based on this interim PET-CT, we can plan to escalate or de-escalate the chemotherapy. In interim PET-CT, we go for Duvalier scoring, which is a visual analytic score, and based on FDG uptake of the lesions, which is a 5-pointer score, and FDG uptake is compared with mediastinal blood pool and liver uptake. This is initial baseline PET-CT, and this is PET-CT for response evaluation, which interim PET-CT which showed near complete metabolic response to the treatment. These are the coronal images depicting mesenteric lymph nodes and retroperitoneal lymph nodes. And after 2 cycles of chemotherapy, there was near complete metabolic response to the treatment, and we can see that the retroperitoneal lymph nodes healed by calcification, and mesenteric lymph nodes melted like bags, which is a typical feature of Hodgkin's lymphoma. Axial sections also depicted interval resolution of mesenteric lymph nodes in a wax-like pattern, but retroperitoneal lymph nodes healed by calcification. So to conclude, near complete metabolic response to the treatment was noted with morphological residual small lymph nodes, that is Duvalier score 2, and metabolically inactive multiple residual calcified lymph nodes represents healed tubercular lymph nodes, but ascites still persisted. So lymphoscintigraphy was planned. The indications of lymphoscintigraphy are early detection of lymphedema and its causes, diagnosis of lymphatic flow disorders such as lymphatic dysplasia, chylous leak, chylous ascites or chylothorax, sentinel lymph node mapping and biopsy for staging workup of neoplastic disorder, example breast cancer, and initial diagnosis as well as outcome monitoring of an intervention which is done. In lymphoscintigraphy, we take 2 millicurie, that is 74 megabecquerel of technetium 99 labeled sulfur chloride, which is divided into 4 parts, and these which is 0.5 millicurie each, and this 0.5 millicurie technetium 99 labeled sulfur chloride is injected into first and second web spaces of bilateral lower limbs intradermally. Static images were acquired from of lower limbs and abdominal region at 10 and 40 minutes. This is a 10-minute image depicting visualization of femoral as well as inguinal lymph nodes in bilateral limbs. This is a normal finding, and there is no visualization of dermal backflow in bilateral limbs, which is again a normal finding and rules out lymphatic obstruction. 40 minutes at 40-minute dynamic images were acquired, video of which is shown here. We can see the inguinal lymph nodes and or external iliac lymph nodes. This is a 2D image, and we can see that there is a leak on of radio tracer on the left side of abdomen. Which is further diluted 2 spots were obtained, and we draw a midline on images. There is progressive accumulation of radio tracer on the left side of the peritoneal cavity, and due to poor spatial resolution, exact site of lymphatic leak cannot be determined. Further 4 odd spots were acquired, and which showed accumulation of tracer activity, which is on left lumbar region. But exact site of leak cannot be determined, so the patient was sent to the Department of Interventional Radiology for further management. Thank you.
Good morning, respected faculty members and colleagues. As in view of young male with recurrent chylous ascites, and there is an accumulation of tracer on left side in lower lumbar region, lymphangiography is planned. Lymphangiography is the mapping of lymphatics and lymph nodes with good spatial resolution in comparison to the lymphoscintigraphy. It plays 2 roles. as diagnostic for imaging of any lymphatic leak and therapeutic for embolization for any lymphatic leak. The lymphatic system is categorized as peripheral system and central conducting system. Pedal angiography is for peripheral system and intranodal angiography for central conducting system. We did intranodal angiography. We puncture left inguinal lymph node with 22 gauge scalp vein needle. Inject lipidol at junction of cortex and hilum of lymph node under USG guidance at rate of 10 ml per hour with ultra slow speed. Serial fluoroscopy done at 30 minutes, 1 hour and 1.5 hour, and we find there is a contrast extravasation from left lumbar lymphatic trunk. In first image, there is opacification of inguinal lymph node, pelvic lymph node and left lumbar lymphatics. In second image, the left vertebral lymphatics also opacified, and in next image there is also opacification of the cisterna chyli. In first image, we see there is a contrast extravasation from left lumbar lymphatic trunk at the level of L4-5 along the left iliac crest. We do the 3D lymphangiography, as video is not playing. We do the 3D we do the 3D lymphangiography with dynamic CT protocol. Then we target the leakage site. Leakage site is found at the level of L4 with 21 gauge spinal needle from posterior side as patient turns into prone position. So inject 0.5 ml N-butyl cyanoacrylate in leakage site, and the leakage sealed off and output nil within 48 hours. Now I would like to invite Dr. Disha for next round.
So as discussed for the interim PET, the response was good, so we continued with ABVD 4 cycles more. And another PET was done for the disease status, which showed complete resolution of FDG avid enhancements of the lymph nodes that you can see. So this is the PET CT done in April 2023, and there's complete metabolic resolution as shown by complete resolution of the FDG avid lymph nodes.
Metabolic response will look FDG uptake totally
disappear. Yes, so there was resolution. And so there is disappearance of ascites also. Chylus ascites has resolved. And to continue further, I would like to call Dhiraj sir.
This case was challenging for us because it has two common occurring diseases like TB and lymphoma presenting in the rare combination. Also, the chylus ascites itself being a rare condition, and the chylus leak or lymphatic leak is very rare. So we are thankful to the Department of Nuclear Medicine and Interventional Radio for providing us such a high modalities, which are also very rare, which is also mentioned in Western literature that it is also not very frequently available on their side. So with their help, we could identify the leak, we could seal off the leak, and the patient after chemotherapy, after ATT completion and lymphangiography, the patient's fever subsided, ascites completely resolved, patient's appetite increased, patient gained 10 kg weight in 3 months, patient completed his chemotherapy in Feb 23, patient completed his ATT in April 23. Now he is on regular follow-up with us since last 9 months. The first picture is showing at the time of our admission, Now the last picture is 1 month ago. He came us to follow up. Now he is doing well in his personal life and his professional life. He is in his business. Sir. So now, how rare this case is and how complex it is, I would request my consultant, Dr. Rajat Bhagat, to further discuss the complexity and rarity of this case. Sir.
Thanks, Dhiraj. So with this, the case what we have initially was on ATT from outside for 1 month. We persisted with ATT because we have all those features of high ADA and the miliary mottling that we see in PET-CT. And retrospectively also, the calcified lymph nodes that are shown on PET, it is not seen in lymphoma. They are more commonly seen with infective and inflammatory diseases. So that also substantiate. The microbiological evidence was not there. One of the common reason is that the ascites is the peritoneal ascites is basically a paucibacillary disease, and the yield of whether we talk about AFP or culture or even the CB-NAT and the PCR is up to the tune of 30%. Relatively, if you look at the pulmonary tuberculosis and the lung tuberculosis, so there the yield is close to 80 to 90% of these PCR-based tests. So ascites, we all see it is common in East as well as West. When it comes to the various studies in United States, the cirrhosis is the leading cause, followed by malignancy. The tuberculosis is very rare, uncommon when it comes to the countries, developed countries of the world. However, in India also, the leading cause is cirrhosis. But the second most common cause for us is still tuberculosis. And as it is endemic and the incidence and the prevalence rates are very high, though I reviewed the literature which showed that the incidence has reduced, it was around 250 per lakh, which reduced to 210 and from 2015, and now it has come down to 199 per lakh. So we are able to reduce it from 256 to 199 over last 8 years. And the malignancy is the third most common cause here. And important thing to understand is that in the malignancy, we have ascites because of various mechanisms. The one is directly the malignant cells are invading the peritoneum and causing peritoneal carcinomatosis, as we see with pancreatic malignancy, stomach malignancy, and gallbladder. Second mechanism is the portal hypertension. A lot of malignancies like lung, liver, which affects the liver, and there are massive liver mets. There is increase in the portal pressure. So this kind of ascites will be the high seg ascites, which will have low protein and high serum ascitic albumin gradient. The third variant is the chylous ascites, what we see in mostly the lymphoma patients. In this, there is block of the lymphatics and damage to lymphatic vessels leading to. So in the malignancy also, which comprises 10%, it's only 5% out of that 10% to have chylous. And various causes in the malignant ascites, lymphoma presenting as ascites or lymphoma contribution is very uncommon. So we have a case which was quite uncommon to have ascites as a presenting complaint. These are all various case reports that I gone through, and in this the ascites was either the initial presentation or as a part, but it is uncommon to have. There are no long case series. Chylous ascites, what we see in this patient, is also an uncommon entity occurring because of interruption. To diagnose, it is the triglyceride levels that we do in the ascitic fluid. If it is more than 200, we label it as chylous ascites. In the West, again, the cirrhosis is the most common cause, followed by tumors like lymphoma. And country like India, again, the tuberculosis and the filariasis are the diseases which leads to chylous ascites. But still in TB also, it's very uncommon to have chylous. This is actually a paper from PGI Chandigarh, where they have reviewed the literature, and they found 33 patients with chylous ascites which were related to Mycobacterium tuberculosis or in HIV patients because of Mycobacterium avium intercellulare. And these were last 20 years literature they have searched, and they find only 33 such cases. So 3 cases in this, and they reviewed the literature also. So they find 30 more patients overall in the entire last 20-year literature, the search what they have done in this case report. So again, as lymphoma also, so the chylous ascites is uncommon. Coming to the treatment, the most important thing is the treatment of underlying cause. So in this patient also, we were treating tuberculosis, we were treating lymphoma, but still the ascites, even after 3 months of ATT and 2 cycles of chemotherapy persisted. Patient was kept on low-fat diet. MCT is medium-chain triglycerides. So the medium-chain triglycerides, which are present in coconut oil, palm oil, they are directly absorbed in the intestine and goes into blood. The large triglycerides are absorbed through the chylomicrons and then they add up to chyle. So they increase the chylous fluid. So we try to keep the patient on low-fat diet, but still with these modalities, it did not respond. Somatostatin analogs have been tried in few cases like octreotide and somatin, but again, responses were not good. Surgery, if this patient would not have responded to this lymphangiography technique, then last resort is surgery. But again, in such patients with tuberculosis, with lymphoma and poor general condition, it could have been difficult.
इसमें सर्जरी क्या करो?
So इसमें सर जो भी lymphatic leak site है उसको literature में वो they just close that leak sites.
Lymphatic site दिखती नहीं है सर. Cannot see the lymphatic fluid. It's impossible to.
So the actually
Cannot see the lymphatic fluid.
For surgeons,
It's very possible, sir. After doing the lymphangiography, you can ligate it.
Chyle leaks, normally we see after doing a neck dissection, either
Yes.
amateur or after doing an esophagus,
Yes.
where we have a chyle leak. And if it persists, even after conservative management, then we have to go in again and ligate things. Multiple ligations we have to do in the neck.
Sometimes they open in thorax and then they ligate the thoracic duct. That reduces the chyle.
actually in the neck, at times you can detect it with the patient fasting for 24 hours, and then while the patient is intraoperative, give him a high lipid fluid, and then you can see the white fluid coming out from the leak side.
The dictum is if you see the lymphatic duct, you have to ligate it in surgery.
So this is the repeat. TB and Hodgkin's, so we searched the literature. Again, there were various case reports only, there is no long series. Most of them are from the developing countries of the world where the tuberculosis is endemic, and all these patients treated with both anti-tubercular and the chemotherapy. So coming to the end, the association as only case reports are there. It's uncommon to have a combination of Hodgkin's lymphoma and tuberculosis. Still in endemic countries, we still see such diseases. Another problem is to diagnose because there are similar symptoms like type B symptoms, anorexia, weight loss, they are common to both. Lymphadenopathy is again common to both. Chylous ascites is also common to both. So only few things, and like in this case, the presence of miliary mottling, retrospectively the calcification notes, they help us. And another important is the patient was on ATT. He was not that responding and his lymph nodes were persisting. So we have to bear in mind that another disease could also be possible in the same patient. Histopathology and microbiology is crucial to differentiate them. And the tuberculosis screening we do when we start with some chemotherapeutic agents in rheumatology, rheumatoid arthritis, when anti-TNF alpha agents are started. So in that level of immunosuppression, we do TB screening with MT and the chest X-ray and CT chest before starting anti-TNF. Though in lymphoma, still before starting the ABVD regime or R-CHOP regime, tuberculosis screening is still not done, but still it can be tried in endemic areas. And the multidisciplinary approach, as we see in our patients, all departments promptly and appropriately we have worked up, and we are able to achieve the cure of this patient. So at the end, I would like to thank Emeritus Chairperson Sir, Vice Chancellor Sir, Pro Vice Chancellor, Principal Sir, the CCR Review Committee, especially Dr. Lalit Mohan Sharma Sir, who had helped a lot to make this presentation and to correct it. Then I'd like to thank the departments like Department of Clinical Hematology, Oncopathology, Pulmonary Medicine, Nuclear Medicine, and Interventional Radiology who has helped us in the management of this case. I would like to thank Dr. Subhash Nepalia sir, my faculty colleagues and residents from the department, and lastly, very importantly, patient and his family who keep their trust on us despite his ascites was the main problem which was persisting even for nearly 1.5 months. He has to bear multiple taps, chemotherapy, simultaneously ATT, and then after 3 months, basically 3 to 4 months, he was relieved all his features and presently he is doing well. Thank you.